don't know. I don't know how he's now, but he is clinically quite well. And then I had a patient with a long-standing schizophrenia, and he had a Nagalase of 2.30, having had more than 40 years of schizophrenia. And he had a very low vitamin D. And I advised him, he has had a few of these pills of mine, he didn't do anything, but he died suddenly, but he had atherosclerosis of the brain, and we think it has been to do something with that, not as a treatment yet. Then I have a male of 1992, psychosis, like we used to call hebephrenia, starting in adolescence, very bad reaction to the neuroleptics, they didn't do much. And I gave him these pills, and he bettered very good, and he's still quite good. And we are going to step down all the neuroleptics, especially clozapine, because clozapine is also immune compromising with it a bit. And his vitamin D3 is still low, I think, but he's doing very well. He's the T there. It's a Turkish patient, that's why he started clinical treatment in Turkey. I work in an organization where there are many patients from Turkey, Iran, and also Afghanistan. And then we have another patient. Oh yeah, this is an interesting patient. He was operated on because of a gallbladder way carcinoma that was all over the right part of the liver. And he found a surgeon, he is a dentist himself, he found a surgeon in Belgium who took off half of the liver and let stand the rest of the liver. While the surgeon had also to pick 2 or 3 metastases from the left part of the liver just to pick it out. But on scanning, there are still 4 sites in the liver that are cancerous. And I will try. He is quite relatively well. Perhaps to ask him to consider Lausanne. But he's not bad and he feels well. Then I have another patient of 59, hepatocyte of a known reason you could think of, intravenous as to do with that. And you see his Nagalase was 1.90 in February 13, and now it is 1.50, and the last Nagalase is not yet here, I think. But he was only treated with these because he didn't have any clinical problems, and only his liver had some signs of inflammation. He wanted these granules, that's all he used to considering, of course, the intravenous or intravascular. Then there's another male carcinoma of the prostate, who were let to do bilateral orchidectomy, castration operation, but he has lymph nodes and pelvic bone metastasis on scanning. His PSA was then 66, I don't know what it is now, but he started Nagalase on 15th of August with 2.10, and the last one will be that one, 1.80. So I do not know what the third one is, but we have to wait for a little technical problem in the laboratory for that. And then there is a male born 1990, it's one of the ASD patients, and he's doing quite well with this organ ghostly applied DBP mornings, and all these hallucinations, as far as he tells about them, and some behavior that his mother and family know, have been a lot better. And well, we do not have yet a second Nagalase testing. This D3 was also low. It is also in these ASD patients, the few I have a few more, the vitamin D is low, so I just supplemented it. I have another patient, let me see, that's F2, that's a patient with mental retardation, autistic symptoms, and he is a little bit overactive, I think. Oh well, this is G2. is an overactive patient, and he is retarded, but I didn't know whether there was some problem with Nagalase. The Nagalase was 2.90. His vitamin A was low, vitamin D was low, and the toxoplasmosis I do sometimes was negative, and selenium was also low. So I asked the pediatrician to supplement these. I do not know how to do that in a child. Well, I have seen some more patients, like patients with ALS, amyotrophic lateral sclerosis. 2 patients I have seen the Nagalase testing from, but they did not decide to this treatment. And they were elevated 2 times. Chronic fatigue syndrome, they were elevated, the Nagalase testing. And 1 time, a suspected Lyme disease patient, who was more hypochondriac than perhaps ill, in my opinion, had Nagalase of, what was it? Well, I think, isn't it here? Oh yeah, where is the Nagalase? I forgot the Nagalase. Oh no, it was one of the other patients. Well, Nagalase was 1.70, and now he's doing himself a quarter of a milliliter a week. I do not know how he reacts to that. So these were my patients. I didn't tell them as extensively as I do now, but everyone can look them up. And I now want to show the results of the comparison Nagalase with my patients, Nagalase with Yamamoto's patients, and also perhaps the clinical condition. And these graphs are very interesting. Yes, the graphs. Slides. Yes. The first one is, well, perhaps this is the most scientifically interesting. This is Yamamoto, who treated in his first publications colorectal carcinoma, prostate carcinoma, breast carcinoma, and it is normalized for activity in time. That was not easy, but well, it did. And then you see the colorectal carcinoma took more time with his product, he made himself, I don't know, than the prostate carcinoma, what they took more time than the breast carcinoma. Breast carcinoma was the fastest recovery in his cases. And now we go to mine. Yes, please, next. Slide 2. Yes. I hope these are mine. Yes, here you see my patients. Well, a few of my patients that were interesting, and you see that it takes a much longer time. Well, you see here. The one patient F you see here is a patient that now has his bronchial carcinoma. So much improved, has to be between lines, of course. And the patient J, prostate carcinoma, is the one who is quite well, doesn't have complaints, but still has small carcinomas in his prostate. I have a photograph with me, but someone has to read MRI scans, it's not very easy. And now the next one, please. Oh yes, this one. Well, this one is a little bit. My patients were already published about, but in another way than we are normal to do. Like you see, they use tapes for the underline and for the other line Nagalase. And here you see, if you take the same patients with the time and the activity, then you see they take a lot longer than the patients of Yamamoto. Next. No, well, you can see it perhaps, but I don't see it here. It takes a lot more time than the patients of Yamamoto. Well, my patients are mixed, and his patients are prostate and breast. Well, they compare a bit. But perhaps you can next. Yes, that were the graphs, and I have a little bit of a discussion. That is the last. I showed this in the summary, yes. That's it. Well, you see, I told already about these patients, so we can go to the, yes, yes, discussion. Well, for discussion you're all there, but I have some ideas about, I like to call Nagalase more an inflammation marker than a tumor marker, but that's a matter of taste, a matter of history, you know. And there's already a lot of research going on about microglia, monocytes, and macrophages in their function, even about the implicated genes in Holland, especially in bioanalytical psychiatry. You can look for some publications at Professor Drekshagen from Rotterdam University. But the possibility of the use of a relatively simple alpha-Naga or Nagalase test is totally ignored. It could be, these tests could be done, for example, before and after infection, vaccination, operative treatment, and other interventions or situations. Alpha-Naga has a short half-life, less than 48 hours. I was not sure, but Jan told something like 24 hours or so, or perhaps. Also comparing serum and cerebrospinal fluid could be very interesting to perhaps point at the primary site of an infection or a lesion and secondary sites. I predict that there will be a marked difference between depressive disorder and ASD schizophrenia in this. So major depressive disorders react on GcMAF very well, but the serum Nagalase is rarely elevated, as you have seen in my patient with the psychotic depressions, recurrent psychotic depressions for years. And the Nagalase can be elevated in depressed patients when they have other diagnoses like autoimmune disease or something. I didn't find any yet. And you know, there's something interesting. Schizophrenic patients of chronic type normally smoke a lot tobacco over the lungs, and they have 40% less chance on bronchial carcinoma, but even still they have as much chance for heart infarction or perhaps some other disease like COPD and so on. But perhaps that's because of our diagnosis drugs, like we treat these patients for the diagnosis, not for the symptoms after a few years. Well, and then I will acknowledge that the MRIs have shown already a substrate as well for ASD as well for schizophrenia, but still not very specific, so you cannot use it as a diagnostic tool yet. But the existence of a relatively simple biological marker in these conditions could mean a landslide for clinical psychiatry. And the whole of the markers for more sensitive and especially faster alpha-Naga testing, especially so, because it probably will be used also for screening in the near future. The only psychiatrist to win a Nobel laureate was a century ago, von Jarek, with an immunotherapy, as we call it today. He treated successfully dementia paralytica with the fever of malaria. Dementia paralytica, a late stage, I should say, of an infective disease, syphilis. Well, the mal de Naples, or the mal français, or the mal anglais, so they're very predominating that. It was the dominant diagnosis in psychiatric institutions around 1900. It was 80 or 90% of the patients in the institutions had a dementia paralytic infected brain. Nowadays, schizophrenia is, but we do not have an effective cause or any other cause. But perhaps the primary lesion will be found in ASD and schizophrenia in the brain. And in depression, perhaps, normally they have infectious or perhaps inflammation in the lungs, mostly, sometimes in the liver, and sometimes in the gut. My recommendations in relation to these findings, in my modest cohort, would be stepping up dosing 4 times, but we have all heard that things. The prove that it's not only stimulating the innate immune system, but it's making findings of others. We heard about that already, you, Marco, and others. As we see, and Professor Siniscal from Naples also, heart and vascular cells, central nervous system cells, and of course cancer cells. And it's promising. In my experience, Gc-Maf has also effects on granulocytes, or glycosides. The alpha Nagalase content in these lysosomes, in their lysosomes, was measured even before it was measured in blood by Stam and Van Lichelen in Holland in the 70s already. They did it because the other diseases, you know, like the Shingles disease, the Kamano, is it in Japanese called Kamano disease, where Nagalase is very low and it's a very serious condition. But that's more for gene treatment, that's still not available. Infantile autism and acute chronic psychosis reacted already with very small or mucosidosis also already observed in the parental treatment of ASD. To enhance the effectivity of the Gc-Maf use, should be looked in for possibilities by the in vitro manufacturers of the pharmaceutical product, we know. As well as adjuvant therapies will be considered by the therapists, like Amicalin, my colleague, Germany, and my Canadian colleague also uses adjuvant therapies. In my Frankfurt summary, I suggested some possible factors already and will not further elaborate in front of this audience. Adjuvant therapies could be chemical, like DCA or LDN, vegetal, like Anoa muricata, fruit, and Ganoderma mushrooms, and others, such as acupuncture. Is that spiritual, perhaps? And more. And perhaps the last things I will have some discussion, but perhaps there are questions before. Everyone can have this by the firm if they want to read it. Thank you. No serious questions?
Any questions?
No further questions? Any?
Yeah, any questions?
Well, I give any answer if my wit is there. After the Gc-Maf treatment, David?
Yes, Mohammed.
Dr. Hoffman, thank you for this talk.
No.
All of your cancer patients have in the beginning high Nagalase.
Yes. No,
You
also the 2 or 3 of the psychotic patients have. Well, I have a few more that I haven't started the treatment yet because patients that are in an institution, you have to go to the institution, to the doctor that treats them, to ask whether you may use your treatment. And they have, as we call it, cold water fear. That's a German or Dutch explanation of why they are afraid of everything that could not be dangerous at all, like cold water. You know? And those people those colleagues that treat the patients are thinking about it. You know? They want to have not only one publication, like the one of Bradstreet, but they want to have perhaps have also the Antonucci and perhaps also Professor Tapal Adia in New York is also coming with a publication and interesting data. He has also found in a few psychotic or schizophrenic patients Nagalase of 3 and even up to 8. But he doesn't know whether they are treated or not. He's the chemist. Laboratory says. And yes, and your question?
Another question, in your practice, have you had patients that the Nagalase went down to normal, but still they are clinically worse or the same?
Well, I told you, the one patient who has these 2 tumors in the prostate still has the 2 tumors. They have been a little bit smaller in 1 year, but I used only one 0.25 mil intravascular injection a week. The patient did it himself, he was not ill. And well, now, after the second scan, we try to step up the dose, but to tell a patient that he has to pay 4 times as much for the treatment, if the treatment over a year didn't do what it was expected to do. Well, I have to find that out. Perhaps Lausanne can give some answers on that. And there was another patient who got, a year after stopping the treatment, got another cancer. Another primary cancer, not a metastasis, but in the bronchioles. And he was a heavy smoker. He had been a heavy smoker, of course, but he stopped everything, smoke, alcohol, even coffee. Well, that's something. And well, I hope he will go well, but now he does the treatment, but that's not, that's a new cancer, you could say. And he has a year or more stopped the Gc-Maf treatment. So there are no patients that stay bad or become worse, because my patients, especially the first cohort, the first part of it, I tried to find patients that had metastatic signs, but still not third or fourth stage. But I didn't succeed. There were 2 or 3 that were worse than the second or third stage.
How frequently did you do follow-up Nagalase testing?
Sorry?
How frequently were you doing follow-up Nagalase testing? And did you treat with GcMAF until you saw improvement in Nagalase, or until you saw clinical improvement?
How frequently did you do follow-up?
Well, the follow-up to see the patient, or follow-up to do the Nagalase testing. Well, I started already very fast, because the test took 4 weeks at least in the beginning, and now it's a little bit better. But I started with, after the first few experiments, to do it every 8 weeks, this Nagalase testing. And I saw the patient when they were well. Also, perhaps 2 or 3 times in this, but there were a lot of patients, like a prostate cancer patient that didn't get well, but his Nagalase did. He thinks he's a friend of mine. Acupuncture nonsense. It was my ego more that was frustrated, and his treatment was not a success. But I will not link the 2 scientifically, of course. But the follow-up for Nagalase is enough once in 8 weeks. If you have a laboratory that tests it only once a month. Excuse me that I couldn't understand you, but there was some, well.
Hello. This is a question both for you and perhaps for Zoya, if I may. A lot of people going through cancer have problems with Candida. And Candida is something that we know is very sugar hungry. And I know the diet protocol is to eliminate sugar, but Candida infection can make that a very difficult process. Do you employ any strategies to deal with issues of Candida? Do you test for Candida?
Well, I can be sure no, but I didn't have much signs of real infection with that. It is kind of say, fashion and all to look for Candida and sugar, and to test it and so on and so on. Well, some patients feel well, some patients do not feel well and still do not have Candida, but I'm not sure. It's not all of these things that I do, but none of the patients did have problems with Candida in the mouth or in the vagina, as far as I know. But perhaps in the gut, I'm not sure, but well, I didn't look especially on that. And if the patients had, perhaps, like the depressed patients, they had perhaps an infection somewhere. That's why the infection was primary, the depression was secondary, and the treatment was just for the primary infection. With vitamin D2, but not the doses of my German colleague gave. But the depression did well, but didn't have Nagalase. Not every infection, even if it's chronic, has a Nagalase elevation, I think.
We just asked Dr. Zoya if she has a view on that.
Yeah, I do deal with Candida on a regular basis, and Candida is part of normal flora. However, it becomes pathogenic when there is an imbalance in the immune system, and when it actually pulls the roots into the digestive system, opens it up, and then you have food allergies and you have continuous immune system issues because then the stuff gets into the bloodstream and then it becomes an issue. So two main factors in terms of dealing with Candida is maintaining proper flora, going back to the not just Acidophilus, it needs to be multi-strain, various type of bacteria well balanced. I use Brava probiotic, but I also supplement it with, and it seems to be working in synergy. There's a supplement called Central, made by author Andrew Medical. It's a very nice combination of probiotics in conjunction with enzyme. Enzyme digests the shell of Candida, and then probiotics can compete with the actual microorganism and drive it out, keep it under control. So that's how I deal with it. I do not see Gc-Maf helping with Candida, but in terms of keeping things in balance, making sure there is absolutely no fruits, because fructose is a very high fuel for Candida, and the only sugar that I allowed is green apple, which is very little sugar, it's mostly vitamin D fiber, and blueberries, blackberries, raspberries, because their sugar is maybe high, but it is bound to bioflavonoids, and there is more fibrous content, so people can do that. This gives nutritional component, but absolutely no sugar, and keeping gut in check. And what I also find, if you have good levels of bacteria, the requirement for certain immunotherapies also goes down.
Thank you.
Yes, I want to add a little bit. I have also had a few patients that had, like we call it, F-ptosis, recurrent viral infection of the mouth. You know, F-ptosis is a little bit painful, and it does very well, even on the little granules, but also with one shot perhaps, I'm not sure. And one patient developed, who was only treated with the granules, he developed shingles. And it was, I just had to step up the granules and it stopped after 4 or 5 days. You know, shingles is also a varicella infection that returns. Anyone who want to put some fire in the discussion? Yeah. Thank you for your interest. My English is not very well. I'm in the notes too, so.
Can I just have a show of hands? How many of you ate some Bravo probiotics this morning? Well, it will be out there again tomorrow. Make sure you do know it's Bravo probiotic that you're eating. And we do have quite a bit of Bravo here for those of you who want to buy some to take home with you. And very quickly, we are looking for another doctor for our Swiss clinic as it expands. So if you know a doctor who wants to change a career, who wants to get rid of tumour cell mass at the rate of 50% every fortnight, do put him in touch with us.
What age do you like the doctor?
We haven't got any criteria for that yet.
Does he need to be oncologist?
No, I don't think so, because we can teach them everything they need to know. I'd now like to invite Joanne Spinks up to the stage. We met Joanne about a year and a third ago, and she was in a bad way, but she'll tell you about that. But she is a much happier person today, and she will tell you why.